Hey everyone, welcome tonight. Thanks for joining us for part one of our series on Instigating Change, a discussion on race in ophthalmology. I'm so happy to have you here and that you want to be part of this discussion. I'm Gaynor Freeze, I'm the Executive Director of OWL. I want to give a special shout out to our sponsor for the webinar series, Connie Okeke. Thank you to Monty and Jared and the team over there. We really appreciate your support and helping us to bring this series to life. So thanks so much. Also want to give a shout out to OWL's partner companies. We're so grateful to have support from J&J Vision, Zeiss, Novartis, Alcon, Star Surgical, Bausch & Lomb, Allergan, and RB Company. We really appreciate you guys and all that you do for ophthalmology. For those that aren't familiar with OWL, those initials stand for Ophthalmic World Leaders. OWL's vision is to promote and develop diverse leadership to advance ophthalmic innovation and patient care. We're the only organization that works across ophthalmology, uniting all stakeholders. From its inception, our purpose was to raise underserved populations in ophthalmology. OWL started as a small 501c3 nonprofit, which was focused on elevating women. And in 2015, the board took the decision to broaden our focus to advance diversity in leadership, whether that be diversity of gender, race, age, sexual preference, or thought. We know that when everybody comes together and embraces our differences in all areas, that everybody wins. And so following the recent very public cases of racial injustice that have inspired so many hearts and minds to open, our leadership determined to open discussions within our community and within our channels, and this led us to this series of webinars. So it's my pleasure to introduce you to our very esteemed panelists this evening. I'm going to try and do them justice in a brief overview of their impressive accomplishments. First, we've got Dr. Connie Okeke. Connie's the lead glaucoma specialist at Virginia Eye Consultants, and she's also an assistant professor of ophthalmology at the Eastern Virginia Medical School in Norfolk, Virginia. She did both her undergrad and medical school at Yale, where she won several awards for academic achievements and research efforts. She performed residency in ophthalmology at the Wilmer Eye Institute at the Johns Hopkins School of Medicine, and then pursued subspecialty fellowship training in glaucoma at the University of Miami Bascom Palmer Eye Institute. Among her many pioneering accomplishments in treating glaucoma and cataracts, she was the first in the country to combine trabectome with femtosecond laser in cataract surgery. Dr. Okeke is regularly featured in many ophthalmology publications, and she also has a glaucoma educational channel on YouTube called iGlaucoma. That's I like iPhone. And as a pioneer in the area of MIGS, her videos include a series called MIGS University. I'd also like to introduce you to Dr. Frank Bowden. Frank is a corneal glaucoma and refractive surgeon, as well as a dry eye ocular surface specialist based in Jacksonville, Florida, where he's spent 31 years in private practice. He's the founder of Bowden Eye and Associates, an integrated comprehensive practice with 3 locations. Frank's the owner and medical director of the Eye Surgery Center of North Florida. He's currently the section chief of ophthalmology at Baptist Medical Center Systems in Jacksonville and is the co-founder of Dry Eye University and Dry Eye Access. Dr. Bowden finished the University of Tennessee with highest honors. He was valedictorian of his medical class at Meharry Medical College and HBCU. He has the distinction of being the first African American to complete an ophthalmology residency in the U.S. Navy while stationed in San Diego, and was the second African American to complete a corneal and external disease fellowship at Wills Eye Hospital. He recently resigned as the ophthalmology consultant and provider to the Jacksonville Jaguars of the NFL after 23 years. I'm delighted to have you here. And last but not least, Dr. Renee Bovelle. She is the owner and medical director of Envision Eye and Laser in Maryland. She graduated from Wellesley College and UCLA Drew School of Medicine and completed an ophthalmic residency at Yale and a cornea refractive fellowship at LSU. Dr. Bovelle also holds academic appointments at Howard University Hospital, Ross University School of Medicine, and the University of Maryland Capital Region Medical Center. Last year, Dr. Bovelle completed a master's in cybersecurity strategy and information management and focused on policies and practices in the healthcare field. She's co-authored CME courses on cybersecurity for physicians and the first cybersecurity CME for the AAO. Dr. Bovelle is also a senior fellow of the University of Maryland Center for Health and Homeland Security and is a valued member of the board of directors of OWL. Whew. So makes me wonder what I've been doing with all of my time, but I am so thankful to you all for being part of this discussion, and I will hand over to Dr. Bovelle. Thanks so much, guys.
Thank you, Gaynar. We appreciate those lovely introductions. I'd like to get right started in what we're going to be talking about today. And at OWL, we do recognize that racism is a public health problem. It impedes the ophthalmic health of our patients and limits industry growth. Diversity initiatives have proven to have a direct impact on business revenues. In addition, successful businesses that understand the economic impact of changing demographics have developed products to fit the needs of our changing population. Diversity initiatives and successful results help organizations in attracting high caliber talent with diverse skills and perspectives. These organizations realize that high quality talent resides in all population groups, thus attracting the talent that improves the quality of the organization's workforce and competitive advantage, increasing the ROI for shareholders, investors, and other stakeholders. Today, customer bases are more diverse than the actual workforces. Organizations whose workforce composition reflects their customer base allows those organizations to identify and understand their needs. We also realize that diversity in and of itself does not automatically make racism magically disappear. To that point, our webinar series, Instigating, Connie and I share some of our experiences and then open up the floor for discussions, and we'll make the recording available the next day or so, and we'll also be looking forward to follow up. So I'd like to start today by asking Frank, what kind
So Renee, I'm sorry, we're having a few technical problems with your feed. So I will perhaps move to just put the first talking point to the panelists, and then hopefully we can have you join back in. Okay, so sorry about that. So Connie and Frank, so we hear that only around 6% of ophthalmologists are people of color. And I'm wondering what the diversity of your residency look like. Did you guys have a very diverse class, and why do you think the rate was so low, if not?
Well, I'd like to start off with to clarify, those 6% of ophthalmologists are from underrepresented minorities. Among that 6%, 2.5% are Black, and 3.3% are Hispanic, and 0.2% are Native American. In my particular, residency, I was the only African American among all the residents. And in fact, in 1984, I was the first African American to finish the program of an ophthalmology residency in the U.S. Navy. Reasons for that lack of diversity is probably multiple. One of which is ophthalmology obviously is a very competitive residency to aspire to, both from an academic standpoint, and in the Navy. There was significant weight given to your prior military service, your prior duty that you were assigned to, whether aboard ship or abroad or what have you. So clearly it was a reward for service to be considered for a hard to get, so to speak, residency program. Another point is that oftentimes ophthalmology is a low consideration among medical students and interns to even aspire to or consider. So that factors into it as well. And oftentimes I found that the military pathway for postgraduate education was not a very popular option back in the day as well.
Awesome.
So for me, in terms of my residency program, I actually had the fortune of having someone who was another female of color who not only was a year ahead of me in my residency program at Johns Hopkins at Wilmer, but also was in my medical school at Yale a year ahead of me. And when I had gone through the halls of Wilmer to look at the different pictures of previous residents, I had come to find that I was the third Black female in the history of Wilmer, graduating in the class of 2004. I will say that the diversity is something that when you have someone who looks like you and someone you can emulate, it definitely can have a major impact on where you think that you can go. It was Camille Hilton. She was a year ahead of me, and she was a good friend of mine in residency or in medical school. And when she was interested in ophthalmology, it was one of those things where I remember reaching out to her, and she mentored me. And the fact that she went to Wilmer made me feel confident that I could apply. And I think that in ophthalmology, one of the things, I mean, it's a very coveted field, and there's a lot of people who don't know about ophthalmology. We don't always get as much training or get access to knowing about ophthalmology early on, and it's a very competitive field. I had myself it was more serendipity to stumble into glaucoma research when I was in college at Yale, and my mentor, Joseph Caprioli, just guided me along and saw something in me that just had encouraged. So I think that part of the problem why there's not enough people of color or Blacks in ophthalmology has also to do with just not having access to the field early, and then not having as many people who look like them to think that they can do it too. I can tell you that any mentorship program where we have early touches with other people who are younger than us, who are people of color, there's a significant amount of encouragement to allow them to enter and have that confidence to be able to even apply for the positions.
I would agree with both Connie and Frank as well. I didn't know I wanted to go into ophthalmology until the end of second year. And when I told people I was interested, they said it's probably too late because I hadn't done any research at that time. But at Drew, I was, I suppose, lucky enough to find mentors at the ophthalmology department there. And they took me under their wing and guided me. And I did get a chance to do research and was successful in obtaining a residency at Yale. So we were both at Yale, although different times. Connie, I think I was there before you. However, I was the third Black resident at Yale, and that was in 1993. So there's still room for, I'd say, a lot of improvement in terms of making ophthalmology more accessible, having more exposure for medical students. And I think that's a way to increase more Black people in ophthalmology. We just have to make it more aware. We have to have more mentors. And I think we have to have more guidance as well. Related to that, I'd like to know from both Frank and Connie, what kind of experiences have you had with patients, either being pleased that they're seeing an African American ophthalmologist, or in some cases, maybe not so pleased?
I can start out. I can remember two patients in my career that actually refused to be seen by me. One in the Navy, and it was kind of like I was surprised and kind of, but it was fortuitous because I was running behind in the clinic, and it was great because that allowed me to get to the next patient, and it fell on my coworkers to deal with that individual. And I've only had one patient in my private practice here in Florida, deep south, that essentially walked out of the office when they realized I was an African American doctor. And but my attitude is that if you have a problem with me and my appearance, it's really kind of your problem. And that's my coping mechanism that's worked well for me over the years.
And Connie, what about you?
Yeah, for me, I mean, I will say that it's something that I won't necessarily say that it's always so overt. There'll be times when I'll have a patient who will wonder, say that they thought I was going to be a man, maybe think I might be Asian because of the sound of my name. Ask, if I'm the nurse, is the doctor coming in? And earlier on, you say, okay, well, maybe it's because I look young, at some point, but it still comes. I won't say that I feel that it is as often, because maybe more of my referral base are coming because they know they've heard of me or they're referred by me based on reputation. But it happens. And to be honest, I've always seen it as a challenge that I want to, a challenge that I take on, because in my mind, I'm like, you're just seeing me from, the face, your first impression. It's almost like I want to turn their impression of me by the end of my visit with them. And that's based on being able to clearly discuss things that are happening in their eye, from talking to them about what's happening in their eye in the slit lamp exam, because I dictate to my scribe, then to being able to clearly explain to them what's happening and confidently tell them what the plan is going to be. And it's always it's always you kind of almost feel it in the room when you come in. People will have their arms fold like this and be wondering, what are you going to say, or what do you know? And then by the end of the conversation, I have them like this, like, tell me more, doctor. I'm in your hands. Whatever you want me to do, I'll do. And I feel like the challenge is on me to try to be a good example, because I want to be able to leave an impression with them that maybe this one instance they will say, okay, well, I had my interaction with a person of color, a doctor of color, and they made me feel confident. They made me feel good. She did a good job for me. And maybe somehow that will change their impression in the future, that maybe when they see someone else of color, they won't automatically judge them just based on how they're looking. So I embrace it as a challenge. I kind of throw it off as something that I figure that by the end of my interaction with them, I'll have them, I'll have them hooked, So, but that's how I deal with it. I don't really internalize it or get mad. And I feel it's almost like a duty and a calling for me to do. I've been given these gifts, and if that's something that I can do to help, that's one way I can. So that's how I see it.
I'd like to add with that I agree totally with Connie's characterization. I've shared that as well. But one of the things our colleagues may not appreciate, the fact that we have to endure this on a day in, day out basis. I mean, every time you walk in for a consultation with a new patient and you get the look or you get the body language to indicate their skepticism, it's like showtime. It's like you have to turn it on, you have to turn it up, you have to win that patient, and you may not realize it, but that cumulative stress day in, day out, you leave the office exhausted. But it's gratifying to hear when I get my end of day report and I find, oh, that person that was the challenge, they signed up for surgery, they're scheduled for the procedure, or they followed all your instructions. And that's, it gives you the motivation to keep fighting the fight, if you will.
I agree. I've had similar experiences as both of you have. I've also had some experiences with patients saying, I'm glad to see that you're Black. I know that you had to work extremely hard to get here, so that makes me feel more comfortable with you. I've had not as many, but I have had that happen a few times, especially at the VA when I was in training at the VA, and even now when I deal with veterans, they'll often tell me that, and then they'll tell me a story of how when they were in the service, a man of color helped them or saved their life, and how grateful they are. But I do agree that having this always in the back of the mind does add to the baseline level of stress. But I don't think it prevents any of us from doing our job. I think it's just something else that we take on.
I've even had, go ahead, I'm sorry.
Oh, I was going to say, and the other thing that is rewarding, I often have my African American patients tell me how proud they are of me and how comfortable they feel having a person of color. And that makes me feel really good. So it kind of helps to balance things out a little bit.
I've actually had the same situation where I've had oftentimes some of my older patients insist on, this is of course pre-pandemic periods, but they would insist on bringing their children in, bringing in their grandchildren, because they took pride in my success. They took pride in the fact that I, as a doctor of color in a subspecialty area, that they've never seen a provider that looked like them. It was a source of pride to them, and I would always welcome that and spend time with children, because they would want me to serve as an inspiration for their child or grandchild to work hard and dream and aspire to lofty aspirations as well. I've actually had the experience on a couple of occasions where I've had white patients actually, just with the door closed and just us in the room, actually tell me that they felt a comfort level with me because they just knew that I likely have endured far more than they realize, or far more than maybe their other doctors that they've been to get to where I am.
Yeah.
I agree, and that's something I had touched on. I know my mic may have gone out for a little bit earlier, but one thing I was saying is that it's important for industry, it's important for our patients to have African Americans be seen in positions of leadership and also as physicians. And this actually benefits, of course, patients, society, but it also benefits the company and organizations themselves, because when their people who are their clients, and their clients often are people of color, they have to be, because especially in glaucoma, right? When they see people of color in leadership positions, I think that's going to make them feel more comfortable to use that product or to feel comfortable. Have you
I
found
think,
that, especially
yeah,
with glaucoma?
I think that's extremely. I agree with that. Strongly. I think that it's really important for industries and companies to understand that people notice when there's diversity, and people will seek other doctors that look like them. I'm not saying that they won't go to doctors that are, they'll sometimes go to any doctor, but if they have a choice, sometimes they will seek to go to doctors that look like them. And you also have to understand there's a trust factor here. Um, for years, there's history of things that have happened where there can be distrust, and one can wonder if someone's best interests are really in mind. And sometimes they will relay that to you, and maybe they'll have maybe they'll, let's say for example, see a retina doctor, someone that's not in your area of expertise, but they'll want to come to you and ask you if you really think that this is okay, because they feel that you'll be able to tell them the truth. That you'll be really able to tell them what is the best interest, not based on just a person being another number, not based on just trying to get income from the patient, all these different things. And so it's important, and people see it. And when there's diversity, people respect it. People respect the industry, respect the organization for being mindful enough to look for people of various diversities that are good to be present and to be available. And it is something that you appreciate too, because if you have the opportunity, sometimes it just makes you feel more comfortable. I've heard it time and time again from my patients that they appreciate me being there. All the things that you were saying, Frank. People coming, bringing family, bringing their. I want you to meet my granddaughter. I want you to see my son, or I want, they're so proud, or they'll just tell you how proud they are. I mean, these are important things, and I really think that we talk about how it is important. What we need to do is start to focus on how can we do that? How can people be mindful of the fact that that needs to happen? Mindful of avenues to try to seek good talent, to seek diverse talent, and bring them in, and make ways for the diversity to spread in ophthalmology. I think that that's something that we should be talking about.
I agree, and I think that having people who have had to maybe go the extra mile, such as Blacks, African Americans, to get somewhere, also can bring a diversity of thought to industry and help them think about um, issues in new ways, not just issues surrounding ophthalmology, not just issues surrounding African Americans, but maybe how to solve a problem. What's a different way of thinking about a certain molecule? How else can this drug be used? Because I think when you have constantly had to think outside the box, that's a skill that you bring, and you're going to automatically bring that skill no matter what arena you're in, whether it's seeing patients, whether it's working on drugs, whether it's working on research. And that brings me to another point I wanted to discuss. In terms of research and clinical trials, how have you found the diversity in drugs that you use and medications that you use and participation in clinical trials, both as a physician and also in terms of looking at your patients? How many of the patients have been African American in these clinical trials? Frank, do you want to take that?
Sure, I'll start off on that. I would say one of the biggest challenges that we had initially in getting involved with clinical trials was to essentially have the credibility, or in the industry, street credibility, if you will, because we had to invest in obtaining a quality clinical kind of module, a person to essentially run our trials and to manage be the interface person with the companies and the like. And until we had that quality person in place to organize and to get our clinical trials up to speed, it was kind of like an aspiration, but we couldn't quite get it delivered. We couldn't get it going. And so now we're up to speed, and we're participating in dry eye and glaucoma trials and the like, and it's certainly we're very rewarding. Our patient base is probably about 30-40% African American, and so I'm in a position, as well as my fellow docs, to offer these clinical trials to all of our patients, and we have ways to make them visible, with advertisements in the waiting room, and bring it up with patients that we identify that are reasonable candidates, and they're very receptive. So I think we certainly can attest to a diversity in our practice with clinical trials that we're involved in.
And Connie?
Yeah, I mean, for me, I've had the fortune of being in a practice, Virginia Eye Consultants, that has a long-standing history of research. And so when I came in, that was one of the attracting points, was that they had a research division. And so I personally have benefited from being able to have a lot of access to clinical trials in the medical medicines, devices, MIGS devices. And so for me, I've had that fortune. So I haven't had a problem in terms of diversity with the patient recruitment. There is good diversity. When I think about patients who I'm recruiting, my population is a mixture. So when I recruit patients, I'm able to get a mixture of patients. So their diversity is good in there in that regard. Yeah.
Good. I think it's especially important especially in fields like glaucoma, which does affect African Americans more, and it's more aggressive in African Americans, that we have a solid representation of the people that it affects the most in these clinical trials.
But I will make one point. I'm sorry, I will make one point. If you're talking about diversity, and for me, like I said, I'm in a fortunate position. But for example, if I go to an investigator meeting, I don't necessarily see a lot of other people of color who are also principal investigators. So in that regard, there is some limitation. So I'm speaking from a viewpoint that is a bit skewed, but when looking at the larger picture, there's still a lack of good diverse representation of principal investigators in clinical trials. And why that is, I can't attest to that. That has to do with a certain aspect of getting studies up and running. How do people get all set up? Those things have already been established for me, so I can't speak to that. But I do see that the lack of diversity amongst principal investigators.
Well, I think part of the reason may be is that the industry tends to go with who they know, and they may not be familiar with the African American ophthalmologists, and there are not that many of us. And so they keep going to the same people over and over and over again. And I think it's incumbent upon industry to reach out and guide and bring new talent in so that there can be a broad swath of diversity in clinical trials. Were you going to say something, Frank?
Yeah, I was going to say that one of the things that drives that industry reach out is that they have to really make an effort to understand our individual practices, particularly practices owned or run by African American doctors. That the success that I've had with our industry partners has been a result of their efforts to actually come into my practice, understand the dynamics of my practice, the diversity of the practice, and the volumes. One of the problems that has probably plagued some practices is they may not demonstrate that they have enough clinical volume of the pathology that that the industry is interested in, and the like. And if industry has limits on those practice on those doctors or those investigators to have minimum numbers of anticipated candidates for the program, you're kind of like put on the back burner, or we'll call you if we need more candidates or and the like. So they tend to go where the best likelihood of their reaching their clinical numbers in a shorter period of time and the like. So I mean, there's partly they would have to really reach out and make an effort to be inclusive with African American investigators, I would think.
And I think that's important. And there's always a place for a sub-I. Maybe, someone could be, you work with somebody close by, have a sub-I, bring more African American patients, things like that. So I think that there certainly is room for improvement, and that it can be done with not a whole lot of extra effort, but I think it can be done. One other point I wanted to bring about, in light of the protests that have been going on, and in light of the men and women that have been killed, I think it's important to recognize that this kind of racism goes across all socioeconomic strata. What we've seen in the news tends to be people who are maybe in a lower socioeconomic strata. But I wanted to share a point that I myself, maybe about 10 years ago, I was stopped by the police. I was driving a car, and the policeman just said he wanted to see if the car belonged to me. He just stopped me. I was stopped at a stoplight or red light, and he just turned on the lights and wanted to see if I owned the car. I did. It was a BMW. I don't know. And it was very upsetting. I was angry and scared at the same time. And, my hands were shaking, which, of course, doesn't happen to a surgeon, but mine were shaking. And I, had to dig through my glove compartment to find the license and registration and all of that. And I was like, I want you to know this is my car. This is my car. I should have been saying, why didn't you stop me? But for some reason I went to, I have to prove to you that this is my car. And I don't know if any of you have had any incidents that you feel comfortable sharing about how racism may have affected you personally that way.
I have a couple of instances. Probably the first one early in my career was to go to national meetings or professional gatherings, and if I had neglected to put my physician badge on, I would be my initial impression that someone would greet me as a sales rep, and because oftentimes I would be the only African American face at the meeting, or one of very few, and that was one of the early kind of how do you say, micro transgressions, if you will, or just little irritating assumptions that someone made, just and not giving me the benefit of the doubt of being considered a physician first. I had one other personal experience with a friend and a coworker that, interestingly enough, he in a moment where we were, we were actually at his home with our wives, and he just kind of like offered a compliment. He wanted to share with me that when he saw me as a colleague and a capable doctor and the like, and he was colorblind to the fact that I was African American. And I kind of winced, and I felt comfortable enough sharing with him that his attempt to compliment me was actually offensive. I
Right.
told him that I want you to see me as a black man who just happens to do what you do, to be a physician. And it was like an opportunity for me to challenge, to be disruptive to his bias and his prejudice about black men. And it was, I mean, we've remained lifelong friends, but it was an opportunity for me to hopefully change his perception of men of color, to give them the benefit of the doubt and treat them with respect, and that they likely have the same aspirations, the career aspirations, the same values as they do.
That's right. Connie, did you want to add to that?
I'm not going to say that I have any story where I have been say pulled over, or to be honest, there's so many different things that happen, and my personality is more of one to push past it. And I have so many plans, dreams, aspirations, and I don't have time to really let it keep me down and fester on it. There have been times when I felt frustrated, where I was thought of as someone who was definitely not the doctor. Almost like I had to convince people that I was. But it typically, once I start opening my mouth and speaking, they know that okay, she sounds like she's deserving of the title. But yeah, it is something that you get so used to it, unfortunately, that it becomes the norm. Yes, I do notice that I might be the only Black person in the room, or the only Black person in the organization, or whatever. But I quickly go past that, because that's not my purpose. I need to represent. That's my purpose. And so I'll just leave it at that.
Very good. Well, I know we probably have some questions from the audience, and I'd like to ask Gaynor to come back. And Gaynor, can you read some of those questions, please?
Yes, absolutely. Yeah, thanks for really being willing to share those experiences. It's really awesome. We have a lot of questions. I know we won't get to them all. I'm sorry, guys. We'll try and answer them or use them as inspiration for future sessions. A great question from Brian. In which ways do you think increasing diversity can help decrease healthcare disparities that exist among individuals from underserved communities?
Do you want to take that, Frank?
Yeah, I'll start out. Oftentimes, members of underrepresented minorities tend to gravitate in those healthcare areas that are most beneficial, meaningful, impactful in underserved areas, such as your OB, your family medicine, internal medicine, pediatrics, and the like. And so it's hard to make that kind of an impact in ophthalmology, because the African American population is like about 13%, the U.S. population, and we're only 2.5% of the ophthalmic workforce. So any opportunity to demonstrate our visibility or to have the visibility can certainly help improve trust, improve access to patients who need our services to be more receptive to and more compliant with our recommendations.
Very good. Gaynor, is there another question that maybe Connie can take?
Yeah, so Connie, here's an interesting one for you. Have you had to prove yourself as competent more as a person of color or as a woman? What's your thoughts on that?
That's a
Be
good
hard to
question.
separate. Yeah.
I think that it is hard to separate, although I feel that in ophthalmology, in terms of uh, gender, I feel that we are increasing in number such that it's not as uncommon to see a female ophthalmologist. Now, that's in terms of the patient relation. I think that in terms of getting access to working with industry, um, I still feel that in the areas more specifically of glaucoma, that there is work to be done in terms of um, being a female of color. But I mean, I still feel like first is more color, and then second is the gender for what I would be dealing with. Uh, and I think that um, it's a little bit of a confusion, but I think that the color is going to be the first one that I would have to combat with first, and then the gender would be second. I hope that answered the question.
Yeah, interesting. Yeah, thank you for that question, Denise. Okay, one more question for you guys. Maybe you could all chip on this one. How could industry help to advance an inclusive environment within ophthalmology? What do you think that our industry partners could do to help encourage a more diverse workforce?
Let me just take a stab at that one. I think that there are certain industries that do better job than others. I think that there are certain industries that understand that it's important to look and seek for good talent and try to make that diverse and to still keep working on trying to increase the numbers and not trying to stay with the same people over and over again. I think that one could be think outside the box and try to go to your KOLs and ask them about who they think are rising stars in certain areas and seek out those people or look for them or look for their work and consider asking them or inviting them to participate in something and then see how they do and see if let them have the ability to prove themselves or show themselves. I think that there needs to be a bit more of a concentrated effort, and I think that the industries that do it already do it well, and I think that they're intentional, and I think that they understand that their products they want it to be something that is accepted by a wide variety of surgeons or a wide variety of ophthalmologists. And similarly, products might be a wide variety of patients. And so in order to get access to those different groups, it's important to also appear diverse in your work and in your industry and also who you're choosing to help represent you. So I think that the one can be more intentional.
I would agree with that. And I think it's not only just in terms of research, I think it's being on boards, being on corporate boards, being on advisory boards, and um, being willing to listen and being willing to groom someone that you feel has potential, because no one arrives to any position already just there. Everyone is groomed and is helped and is guided. And I think it would be in industry's best interest to reach out and do that. And if you know someone, you may say, hey, are you interested in doing such and such. You seem like you would be good here. And if not, do you know someone? Maybe the academic centers, they could start at the academic centers and ask, or ask, you know, the reps if they see someone who maybe has potential. Do you have anything, any other ideas on this, Frank?
I would say that, it's important for industry to, when they're identifying, private doctors to work with, partner with, and the like, to not have arbitrary, what minimum volume of surgery or minimum volume cases that you do, or interactions with their product as a criteria for even showing interest, because not all of us, do 1,000 surgeries a year or 1,000 cataract surgeries a year with premium IOLs and the like. We're doing them. We have great results. We have good outcomes and the like. But just because we're not doing, 1,000 of your lenses, should not limit us from inclusion in ad boards and presentations, and opportunities to partner with the companies.
One other idea I had was also if companies do take their KOLs and they provide opportunities for those KOLs to talk to up and coming other colleagues and talk about things that they did, or ways that they became a KOL, or things that they felt helped them to be chosen as one, or things that they did, or recommendations. Providing opportunities for people to even know what to do is something that should be happening more often, in order for people to understand that there are certain paths that they can take that can make their chances of working more with industry happen. And in that way, it's a symbiotic relationship, because there are people who are out there who want to work with industry and have the ideas and have the talents and have the speaking ability and have the ways to communicate what they feel their products are doing well or not, that can be paired up with the companies who are looking for those talents, because not everybody wants to be a KOL, or not everybody is interested or wants to put the effort, but there are people who just don't know how to do it. So if the industry creates more avenues for that shared information, they could be grooming the next generation of their KOLs and have more people to choose from.
Agreed. Gaynor, do we have
Great.
time for a question, or is that about it?
Yeah, we can do another question. We have had some great questions about residencies, and we can perhaps, I'm going to use those questions to form talking points for a future session for sure. So let's take one final question. Gosh, so many good ones, guys. Thank you so much. So here's a broad question. What suggestions do you have to impact change, either within ophthalmology or within society in general? Do you have any thoughts on things that that people can do in their everyday lives?
Frank, you look like you're about to say something.
I don't know. To me, it just seems to boil down to mutual respect. I mean, if people don't respect other individuals, that it just lays the groundwork for prejudice and bias to fester and to not improve. It justifies bad behavior when you don't regard a person who doesn't look like you as having, the same humanity or the same, desires, values, and aspirations that you have. And that's got to be I think, a starting point.
Connie?
I think one needs to acknowledge that there does need to be change. Two, one needs to self-reflect and just think about ways that maybe you can change your perspective or realize that your perspective does need to be changed. 3, just start doing something different, whether it's to say that, I know that I'm a bit judgmental and I make assumptions based on color, and maybe try not to do that. Maybe have situations where you give people a bit more of the benefit of the doubt, or you try to not like I said, make a certain assumption. Okay, these are deep-seated things that we've been doing and maybe not even realizing that we're doing it. And before we could even start to change, we have to acknowledge that, maybe I have been thinking in a way where I'm making certain judgments, and I really shouldn't. And I think that, one, we need to create more avenues for uh, um, people of color, minorities, to have access to information that will help them to be good leaders and be good examples. We need more good examples. The more good examples we have that people can look at and emulate, the more people will say, hey, I can do that too, or hey, I want to be like her or him, or we just have to keep creating more avenues in order for people to change. Because I can tell you that only reason why I'm a doctor is because my father was, okay? And the only reason why I might look towards doing something is because I saw someone else of color doing it, or I saw another female doing it, or saw someone else. Maybe it's not someone of color, maybe it's another person, but it's by emulating, it's by seeing. And so the more opportunities that we can make so that people have good role models to be following, and people have good mentors to be reaching out to get information, the more there can be some kind of change.
Well said. Well, Gaynor, we're right at 8 o'clock.
We are. Well done, guys. We kept it right on time. We had, I will just mention quickly the next 2 sessions. This was the first one in our series of 3. On July 8th, we have a session on becoming an agent for change, and that will be led by Patricia Morris and Dr. Craig Paizo. And on July 15th, we'll be talking about the next generation, and we will have Dr. Keith Carter from AAO's MOM program, and Dr. Melissa Ajunwa Bahonas. And we will, as I said, we've got lots of great questions around residency. We'll use those to form our talking points for that session. So thank you for being part of the conversation. I want to sincerely thank Renee and Connie and Frank. Oh my gosh, you guys were amazing. Thank you for sharing so openly and giving us all lots of things to think about. And I really hope that this session starts to make people think about what they can do differently in their lives and their jobs. And maybe we'll start to see some change. Any final comments, Renee?
I think as an answer to that last question, that participating in webinars like this, participating in talking, and as Connie said, listening with an open heart, and you can just do small things. If you're buying books for your school-age children, maybe buy a couple of extra books you can donate to. A lot of the schools in cities need help. Maybe it's something as simple as that. Maybe it's something as simple as when you keep seeing all of this, what's going on the news, all of the protests, instead of saying, oh, brother, what's happening? Or is it going to block my commute? Maybe just listen for a few minutes. Maybe imagining that the person who is white, and then see how you would feel about that, or as your family member, see how you would feel about that. So I think just listening with an open heart, being willing to have hard conversations, and be willing to not be defensive. I think all of those ways are a good way to start. And I just want to thank industry for being willing to participate. I know we had several hundred people register. I'm not sure how many people are on, but that means a great deal, and it shows a lot of caring, and I appreciate that. And I am especially grateful to OWL for putting on the series.
Yes, thank you.
Thank you very much for inviting me.
Awesome. All right, guys, thank you so much. Look forward to seeing you on a future webinar.
Mhm.
Good night for now.
All right.
Bye-bye.
Good night.
Thank you.
Good
Thanks
night,
for coming out.
Bye.